everyone. It's another wonderful day in beautiful Scottsdale, Arizona, and we're back with the Slice is Right podcast with our first honored special guest traveling from out of town to see us, Dr. Stephen Metzinger, board-certified plastic surgeon and more. Welcome, Stephen.
Thank you, Aldo. Thank you very much for having me.
Yeah. Why don't you tell us a little bit about yourself? Where are you from?
So I'm from New Orleans, Louisiana, and my practice is in Metairie, Louisiana, which is a suburb of New Orleans.
Very nice, very nice. And you grew up in New Orleans?
I did.
All right. And have you ever left New Orleans, like just for fun or for training? What do you think?
So I did my general surgery training in Birmingham, Alabama, and I did my plastics and craniofacial in Baltimore, Maryland.
Excellent. So you're, in addition to plastics training, you're also training craniofacial surgery. You did a fellowship?
Fellowship in craniofacial aesthetics fellowship at the facial plastic Galen McCullough. And,
oh, nice.
I'm also boarded in otolaryngology, head and neck surgery.
Right. So you have 3 board certifications.
Correct.
Currently?
Yes.
And they're plastic surgery, facial plastics, and ENT.
That's correct.
Excellent. And what do you mostly practice in New Orleans?
Well, we do a lot of exclusively aesthetic work, breast and body contouring, face and nose aesthetic surgery.
Excellent. Yeah, so kind of similar to us, but you do a lot more aesthetic surgery of the face, would you say?
I think so.
Excellent, excellent. Good. How long does it take you to do a facelift?
It depends on the type of facelift, but we can usually do it in about 2.5 hours because we do a little fat grafting with that as well.
Nice, nice. I'm a little jealous at your efficiency and your speed. But he does beautiful work, and he's well known all over the place, including this country and outside the U.S. as well. But today we're going to be talking about breast surgery, and he also has a very significant interest in breast surgery, don't you?
I do.
Excellent, yeah. Tell me a little bit about your breast practice. Is it mostly augmentation, lift? Is it mostly implant removal? What would you say?
So the majority of what we're doing is explant surgery, implant removal surgery, and then reconstruction of the breast afterwards, which can range from mastopexy to breast reduction to mastopexy with fat grafting to restore volume. And then we're doing augmentation and revision augmentation surgery, which you're very familiar with. Absolutely,
yeah. So what would you say, like in your average week, would you say you're putting in like 50-50, putting in implants, taking implants out for patients, or what would you say?
I would say that's a good estimate.
Good estimate?
Yeah, so we're still putting them in, and we're trying to do it safely and reasonably. But we're taking a lot out and then reconstructing them after that.
Excellent. When you say that you're putting in implants safely, you're talking about triple antibiotic fluid solution, and you're talking about using a barrier between the skin.
Yeah. So we have a 14-point checklist that we use. We start off before surgery, hibiclins, shower, Bactroban, and the umbilicus, the ear canal, and the nose. IV antibiotics at the time of surgery, chlorhexidine prep. We are using a Keller funnel, like you say, and we're doing wash. We're also putting a little marking in the pocket or Exparel in the pocket, so the pH is lower, so that also helps with that. We're soaking the suture material and implants. We're using antibiotic impregnated steri strips, and then immobilization with a Friedrichs Brazier. So.
That's a lot of steps. That's very nice. I use a similar protocol, but I think yours is a little bit more advanced. So what really caught my attention was the Exparel in the pocket. So do you mix Exparel and bupivacaine in together and put it in?
We do. So what we usually do is we call it the 20-20-20 solution. So 20 of Exparel with 20 of Marcaine or bupivacaine, and then just 20 of normal saline to dilute a little bit.
Nice.
And we'll do a little T4 rib block. We'll inject the incision site and put the rest in the pocket.
Do you think, what are you seeing clinically in terms of pain reduction? Are you seeing it for 72 hours, like Exparel says, for the breast?
I don't think it lasts the full 72 hours, but they're definitely using less narcotic pain medication.
Yeah.
For post-op, we always will use a muscle relaxant. We do a lot of dual plane and submuscular work, so that helps, but I think they're using less pain medication when we use the Exparel.
Yeah, so I mean, I did use Exparel quite a lot. I did it for a year straight to see if there was any difference on my patients. I didn't find that big of a difference with Exparel compared to just bupivacaine by itself. And so I stopped using it. I thought it was an unnecessary extra step, but
it's also an extra cost, which is not great for the patients.
I mean, there's a couple ways to do Exparel so that you can lower the cost. There's a 20 cc and a 10 cc mix, and so I use the 10 cc's on most of my patients, which tends to make it more palatable financially for patients. But I think it's worth it because, especially nowadays where we want to keep the patients off, narcotics, we want to keep them on a multimodal approach. So different receptors are hit, and with different receptors, you get them off the narcotics faster, less risk of addiction and other, serious side effects from narcotics and benzos.
Which is great. I mean, we're always trying to use the ERAS protocol to the best of our ability, but for some folks, I think it makes a big difference. I agree with you, and some people, it's really no different from if you're just using Marquine by itself.
Yeah. So we're just a little bit off topic there, but it's good to hear what other people are doing with breast augmentation, since we're doing a lot of this. But we're here to talk about some of the more difficult, challenging cases in plastic surgery of the breast. And usually for those cases, we want to add more tools to the mixture, more tools that give us greater predictability and better long-term results. So we're here to talk about the mesh products. And right now in the market, there are several mesh manufacturers. Two seem to be more popular with plastic surgeons. And which is the one that you use in your practice, Dr. Metzinger?
So we use the DuraSorb mesh, which is the PDS mesh. We used to use the GalaFLEX, but in my hands, I think the DuraSorb is a little easier for me to use, and it's been a little more predictable in the postoperative outcome.
Excellent. Yeah, and we've been talking earlier in the day. We've been talking about different philosophies, but let's go over what you told me earlier at breakfast with why you like the PDS. What specifically do you like about PDS? Which is it's an absorbable suture device that will go away completely, and you thought that was one of the great things about it, right?
I do. I like that we're using an implant. It's already a foreign body, so not having another foreign body in there for a prolonged period of time, I think, is comforting to tell the patients that. I do like the support it gives, so I think there's definitely less bottoming out and better pocket, shaping and retention, particularly for bigger, heavier implants. And I also think the scar is less stretched out over time using it. And we'll use a little PDS like in the vertical mastopexy with it, but even if we didn't, I think the mesh gives a little additional support to that.
Yeah, sure. And so this GalaFLEX here that I'm holding, this will usually go away in 18 to 24 months, but the PDS is going away faster.
In about a year.
Yeah. So you like that security that for a fact that you're telling your patient it's going to go away in a year.
I mean, for me, I think that at a year you're healed. Now, scar tissue is never as good as the real deal. The best tensile strength we get is about 80% with naturally occurring scar. But with the mesh, I think they get a little bit more. And then after that, supposedly it's replaced with the patient's own collagen. Now, I don't think it's one-to-one. And people debate that and argue that. But anytime we get a little more support inferiorly in the bottom of the breast, it's certainly helpful.
Well, I agree with you. A lot of the clinical studies in laboratory animals have shown that both of the products go away within a certain amount of time. The PDS goes away in about 12 months. This is 18 to 24 months. But what's different about the human breast when there's an implant is there's one side that doesn't have that much biologic activity, and that's the side of the mesh that's going to be up against the breast implant. Right. So, and so in my experience, when I've gone back, and I just 3 weeks ago, I had a case where I went back and the patient's 3.5 years out from implants. There was still a significant amount of the mesh pore that you could see in the pocket. Have you had that experience?
I have, yeah, with both GalaFLEX and DuraSorb.
Okay.
So,
yeah.
And I think you're right. It's not in contact with, with biologic tissue. It's in contact with the implant, so it's not going to go away. But I think eventually over time it does.
Yeah, it does. Now, hydrolysis, right? Both of these products go away through hydrolysis, which basically means that we're going to have water impregnate the tissue, and eventually it'll be replaced with human collagen. And there's a huge advantage there.
Absolutely.
Especially compared to what we had before, in terms of the tools that we were using that did the job that these products were asking them to do. And tell me a little bit about what you think about those advantages are.
So we used to use products that were acellular dermal matrix like AlloDerm or Stratus, and you had to use drains because there was so much fluid with it. And that introduces another potential complication in infection, seroma, extrusion.
Right.
I think this is much better from that. And also, the AlloDerm didn't always incorporate with the skin soft tissue envelope from the backside. And I think given enough time, even if it is up to 24 months, this stuff does. And I think that gives us an advantage.
Now, you really loved AlloDerm, right? I remember you used it a lot in the past. Were you using it for the breast a lot, or was it mostly for facial plastic surgery?
I used it mostly in facial, but if somebody had recurrent capsular contracture, I would wrap the implant with the AlloDerm in hopes that would prevent it. And if I'm honest, sometimes it was successful and sometimes it wasn't. I think prevention is a lot easier than curing it. So if I can get it right the first time by using the mesh, I'm better. And now the FDA is recommending you change those implants out every 10 years. I think that helps too.
Yeah, that's nice. So we can reevaluate things and add a little support. So the way that I orient my mesh is down at the bottom, and it tends to act sort of like an internal bra where the implant lives at the very, very bottom of the breast and prevents gravity from pulling on the weight of the device. And, smooth implants will move wherever gravity takes them. So they'll oftentimes go lateral when the patient is sleeping. And when they're walking around in the world, it'll go downwards. Any experience or any thoughts about lateral displacement management with mesh?
Now, sometimes we will do a lateral popcorn capsulorrhaphy at the same time and then kind of reinforce that with mesh. I think that is helpful. If we're doing a true capsulectomy, it is like a little hammock, which you showed, which I think is the best way to hold it. But some people will just put the mesh in there. I will sew the bottom part of the mesh to the periosteum on the rib. That makes me feel better. I'm not sure that it's always necessary, but I do it because in my mind I'm getting a little more security there. And the suture material that I'm using is PDS, which is the same thing the mesh is made out of. So I don't think that it's hurting.
Yeah, so I did a little mini survey. I think 50% of the surgeons in Scottsdale sew it in, 50% don't. It may depend actually on the case, the characteristics of the tissues, whether it's a primary case or a revision. But I'm using the mesh, I would say about 95% of my primary breast lifts, even if they have just minimal weakness, because maybe it's just what people want around here. People want larger breast implants after having kiddos in Scottsdale. It's a sunny, warm state. Do you have a similar kind of demand for bigger implants in New Orleans?
Well, I mean, Phoenix and Scottsdale is so much bigger than New Orleans. And you're seeing more patients than ever. We're seeing a little opposite trend. They're going a little smaller implant in New Orleans as opposed to big implant, but that may be by demographic, what we're seeing. But I agree with you, an ounce of prevention. I think if you're going back and you can put it in and stop it, it's very, very helpful.
Well, that's great. Are there any cases where you wouldn't want to use a mesh, where you would say that I think it's not necessary, or maybe it might even create some side effects that could hurt the patient?
So if I have a patient that has a truly documented connective tissue disorder like lupus or something, I try not to use mesh.
Sure.
Other than that, I like it. I think it's helpful.
Well, around here we have very athletic patients. They're really thin, like BMI 16, 16 and a half in some cases. I tend to avoid using mesh in people who have very thin skin because I think they'll be able to feel it. Yeah. With the DuraSorb, you might not be as worried about it because it goes away in 12 months, and they may have to feel their mesh for 24 to 36 months with GalaFLEX.
So, as you know, New Orleans is probably the fattest city on earth. We have a huge morbid obesity problem, so not a huge athletic problem. But I think that is another advantage to the DuraSorb, that it does go away a little quicker, and if somebody wants it. I also think if somebody's really athletic and doing a lot of chest work and really working the muscle, if the implant is in submuscular pocket, they do tend to get inferior lateral displacement. Whereas if they're subglandular and you support it with mesh, it tends to hold up a little bit better.
Yeah. Are you doing a lot of subglandular, like the Brazilian way, the subfascial?
A little bit. I'm not going to say a lot. I mean, most of what I'm doing is still, dual plane submuscular, and I think that's just what I'm comfortable with. But I don't have a problem with doing that. I think for some people that is the right choice.
So dual plane is the, what the Kylie Jenner was talking about, with the implant half above, half below the muscle.
Right.
Even though that's not exactly what's happening with the dual plane. The dual plane is a really reliable, trustworthy technique. It is the most popular technique. My philosophy with dual plane augmentation in muscular patients is I just tell them not to work out their pecs. Like if they can avoid bench pressing forever, I'd be very happy with that. Push-ups, I think they can do some, but there's so many other muscles on a woman's body that can make them look attractive and athletic, and really make them feel like the implant size and shape fits that frame, that I don't think they need to really work out their muscles.
So the killer for us is when we have women that are doing CrossFit and they're doing pull-ups and muscle-ups and really working the chest muscle. It's problematic. And, you can put the best mesh in the world, and if they don't back off, you're going to have a problem.
Yeah, we have quite a few of those patients that I think I have a few consults of patients who have had surgery elsewhere, and we do try to repair them. But I think the number one thing that we do, it's not so much the tools that we have here like the mesh, but it's really good counseling on what you should and should not be doing with the pec muscle. It's the second largest muscle in the body. There's an example of, I believe that is the GalaFLEX, right?
I believe so.
Yeah, that's a GalaFLEX. That's kind of what I like to use. This one's a little bit more fancy. This is their 3D. I like to use more of the straightforward traditional GalaFLEX, and I think it does go away in less than 24 months for a lot of people, and that's all they need.
Yeah.
These are both natural products. We do want patients to know that. There's nothing to fear here. The chemicals, the basic chemical building block occurs in nature, and it's just a polymerate of those naturally occurring organic compounds, and they will go away. So very safe.
We're using suture material that's already made out of the same stuff.
That's right, yeah. So that's how a lot of these things were first invented. Suture material was first, and then the fancier macroporous design, which is actually, we didn't talk about that, but macroporous is really important because it allows it to more quickly incorporate into the tissue and have tissue ingrowth.
Which is huge.
Yeah, I do have a case to show you. I want you to, and you can be completely honest with me about my results. And do we have that case? There we go. So this is one of my patients. Right now, as I mentioned, 95% of my patients are getting mesh. So this is a case that I did, I think, in the last 6 months. But obviously, level 2 sagginess before the surgery, soft tissue that seems elastic and excessive, with a combination of post-pregnancy changes as well as weight loss. And you see the picture at around a month, and then at 3 months, we have that result there.
So I want to say first that it's a beautiful result, and you've corrected everything you really want to correct: the ptosis, the postpartum superior pole atrophy. So now you have some fullness. Cleavage is outstanding. The nipple-areolar complexes are evened, and it's stable. The mesh gives you stabilization, not only inferiorly, but also laterally. And that's a beautiful result.
Thank you very much. Totally agree. I love the stability with that part. Do you think mesh helps with cleavage?
I do.
How does it do that?
I think it...
Just for the audience.
I think by not letting the implant plop out laterally, it supports that medial edge, so they do get a better cleavage with that. When we're flexing, exercise, activities of daily living, whatever, the implants are trying to squish out laterally and inferiorly. So the mesh is more supportive. We also ask them to find a nice cotton bra that breathes and to sleep in it at night, so when they're laying down, it's not falling out laterally. And I think that helps too.
Yeah, I do agree that helps. And now you also are, part of your clinic has to do a lot with scar therapy, getting good results with scars. So what do you typically recommend for, and you did mention this in your initial introduction, that you believe the mesh helps to get a thinner, better looking scar. What else do you use? Is that all you do, or do you do more?
No, so first of all, multiple layer closure. We believe in doing that. We use antibiotic impregnated Steri-strips for closure, which is helpful. And then we'll use an anti-scarring gel, Biocorneum. We use this afterwards. And then at about 7 weeks, we'll have them do microneedling, which I think helps make more collagen and helps with the scar. If hyperpigmentation is an issue, we'll give them a hydroquinone product that we like. And we stay on them. You know, we emphasize that scar is not healed till they're a year, and they have to be vigilant. So sun protection, physical barrier, sunblock, things like that.
Very nice, very nice. Do you think hydroquinone products that's your favorite approach? What about tranexamic acid? Have you had any topical tranexamic acid experience, or do you believe in that at all?
I mean, I use TXA in surgery for bleeding intravenously, and we put it in a local mix. I personally do not have experience with it, but I have no problem with that. I think it's fine. The hydroquinone, we limit the use for 3 months because we don't want any bluing. We don't want any problems with that. But again, ounce of prevention, if we can get them on the Biocorneum early and prevent them from hyperpigmenting from sun exposure or whatever. We have a large African-American population in New Orleans, so we worry about pigmentation issues.
Absolutely, yeah. I like your ounce of prevention. I think that goes a long ways. It's a very subtle thing, but I think thinking about, I think we all, as plastic surgeons, think about what we can do to prevent. Sometimes a patient will have surgery and they kind of wish they would have had the mesh, but it's not always helpful to the patient, like in the cases that we discussed in particular.
I mean, we don't use it in every case, but if we think we need to use it, it's certainly well worth it, in my humble opinion.
And then let's talk, let's talk a little bit about your website. So you are on Instagram at Body by Metzinger.
Yes.
Oh, excellent. And then on Facebook, do you have they find you under Aesthetic Surgical?
Aesthetic Surgical, yeah. Our practice is called Aesthetic Surgical Associates.
Aesthetic Surgical Associates, and it's aestheticsurgical.com. Is that correct?
That's correct.
Yeah.
Yes.
And he does beautiful work. There's his website. So if you're interested in the New Orleans area or East Coast, I would highly recommend our first guest here, Dr. Stephen Metzinger, triple board certified plastic surgeon. You have some specials going on. You have the back to school specials, you were telling me?
We do have a little back to school special where we're offering a little discount for filler and Botox.
Nice.
We're also offering a discount on dermaplaning with our esthetician, Dana, who's great. So,
excellent. What about you mentioned something about male plastic surgery. We don't necessarily, like most of my patients are women, but you see a little bit of more of a mix.
We do have, I'm not going to say significant, but a fair number of male patients, and we're having specials this month for gynecomastia, for abdominal etching, and for male tummy tuck, which is nice. So I told you, I give you the Tennessee Williams quote. There are only 3 rural cities in America: New York, San Francisco, and New Orleans. Every place else is just Cleveland. So we crack up with that a little bit.
Yeah, it's a good thing I'm not from Cleveland, but that's an excellent quote. And then with the abdominal etching, is that pretty popular? That's when you create a 6-pack. So you're creating 6-packs more than just what goes in the fridge.
Yeah, that's right. So anytime, and I think it's true for male or female patients, if you can define the semilunaris laterally and the linea alba medially, it looks better. With men, we hit those inscriptions too, and I think that is very helpful.
So you're doing women and men similarly, but not so aggressively on men, is what you're saying, yeah.
Well,
which makes sense.
More aggressive on men.
More aggressive on men, I'm sorry, I misspoke. Yeah, excellent. Well, I do think abdominal etching is an underutilized, surgical procedure that I love to do, but just seems that men tend not to find out they tried the gym first, they tried diet and exercise, which probably, if you can do it, that's great, but a lot of people just can't do it.
Well, I think, it's that add a little extra. You've done your conditioning, your diet, your exercise, your supplements, you're doing the best you can, and there's a little area that you just can't get rid of. I think particularly the PAL is very helpful. The power assist light packing is very helpful. Yeah. And they make these cannulas now where you can scratch the undersurface of the dermis, and if you can etch those areas, I think it's very nice.
Super. Well, folks, we're going to wrap it up. It's been great with Dr. Metzinger here of aestheticsurgical.com. And then just for our practice, we have several promotions as well for the summer. One of them, if you have signed up for our newsletter, you know that we're having a $1,000 off on several procedures, including breast lift with implants and mesh, and with breast implant exchanges for Dr. Scott Oakley and myself. And then we are going to be still running a few promos for the next few months, but I know people are busy trying to get their kids back into school. These are excellent back-to-school procedures that are, quicker recovery than our mommy makeovers. So please reach out to us on Instagram at AZBreast and Dr. Aldo Guerra, and also for our photo galleries where it's just photos, Guerra.plasticsurgery. Thank you very much and have a wonderful afternoon. And thank you again for visiting us out here in the warm and, cool desert.
Thank you, Dr. Guerra.
All right.
Who likes it?